Hey, good morning, everyone. Andy and Rick, I think we should probably get started since we've got a couple of really great cases and lots to discuss this morning. I apologize for sounding a little gruff. I contracted some sort of illness the night before I had to give a plenary talk at a conference. So just my dumb luck, but I'm starting to feel just a little bit better now. So remember not to disclose any private health information. Here's our usual reminders about assistance and contact info, and more about cardio, which you've seen before. And this is our team overall, but does not describe who's going to be up today, which we'll talk about in a moment. Our sites, as you can see, Ohio is well represented from across the state. And today, Dr. Werner will be talking about smoking cessation, and he and Karen will be our discussants for the two very interesting cases this morning, which will be presented by Fonda McLean and Robbie Keister. I just wanted to say that I did a session a couple of weeks ago about air pollution and its relationship to cardiovascular risk. And in case I didn't make the point clear, you could live next to a coal-fired power plant your whole life, and it's only a tiny fraction of the damage that you will be doing compared to smoking a pack per day. It's not even in the same. It's a whole magnitude of difference, right? So keep that in mind, that smoking is a huge driver of cardiovascular risk, and that's exactly what Jim's going to talk about this morning with us. So disclosure statements, these are unchanged from previously. And Jim, please take it away when you're ready.
Okay, thank you, Gautam. Good morning. Today I'm going to talk about tobacco use as a driver of cardiovascular risk. So I'm going to talk about the prevalence of tobacco use in the U.S. And also in the state of Ohio, and then talk about a culturally sensitive approach that you can use with patients across diverse populations to help them stop smoking and stop using tobacco. And then I'll list a minimum of two or three resources that you can use that I think will be very useful for referring patients to. So it's been a great public health story over almost 60 years of decreasing rates of smoking in the US from 1965, when it was over 40%, and it was estimated that for every adult in the United States, half a pack of cigarettes was smoked every day. So very high prevalence. To today, we're at about 11.5%. And this has been the product of anti-smoking campaigns, teaching children about the dangers of smoking, smoke-free policies, significant restrictions on advertising, better treatments and resources, insurance coverage of treatments has made a big difference, and taxes have had a major impact on reducing tobacco use. So in Ohio, though, we track higher than the national average by about 6.5 points. So right now, about 18% of Ohioan adults are cigarette users on a regular basis. Ohio has the fifth highest rate of smoking among US states. And we're in this high tobacco use region, bordered by West Virginia, Kentucky, Indiana, and Michigan also have high rates of smoking. Next slide. So looking at how tobacco is used, it's primarily cigarettes that are used by adults, but any form of tobacco is used by more than 1 in 5 Ohio adults. So we have a high rate of tobacco use. E-cigarette use has increased pretty significantly in the last 10 years or so, and I'll talk about that in a little while. So looking at by race and ethnicity, there are some differences, but across the board, really, we have issues across all races and ethnicities in the state of Ohio. In an analysis by the health department, there were no significant differences observed by race and ethnicity. So all of these populations really are priority populations for us in the state. So I think this is interesting. If we look at by insurance type, private insurance and employer provided insurance, significantly lower rates than our average in Ohio of 18%. But look at Medicaid. It's almost 40% of Medicaid recipients are using cigarettes. And we compare this to the national average for Medicaid. It's a full 15 points higher in Ohio than it is with Medicaid recipients across the country. So it's a really significant issue with cigarette use in our Ohio Medicaid population. This is a pretty stubborn number. It doesn't move quickly, and various interventions have been tried, but we just need to keep working at it to help every person we can quit smoking. So there are other disparities in Ohio besides race and ethnicity, and layered upon race and ethnicity. Look at those with low levels of educational attainment. Those that didn't graduate from high school have very high rates of smoking. This also tracks along with low income that you see further down the graph there. Low income and low educational attainment track together very closely. Our LGBT communities also have high rates of smoking, and nationally, these numbers are sometimes much higher than 21%. So this is a priority population for tobacco use. We know those living with disabilities also have high rates of smoking, and this may overlap and probably does overlap significantly with our Medicaid population. Those with poor mental health, we know that those with severe and persistent mental illnesses have high rates of smoking, but also studies showed that those that have ever been diagnosed with depression at any time in their life have significantly higher rates of smoking, as do others with other less severe mental health conditions. So people that you see every day are more likely to be using tobacco or at risk for using tobacco than others. Also in Appalachia, we have high rates of smoking. In Ohio, the two Appalachian regions that are within the state, the northern region and northern central region of Appalachia, have the highest rates of smoking. And this again is overlapping with our borders with West Virginia and Kentucky. Looking at high school students, youth, this is a busy slide, so let's start down at the bottom. It's been a lot of success in reducing smoking among high school students. From 1991 to 2019, we're 6% nationally, and Ohio is even lower than 6%, so that's good news. If we look at cigar smoking, that has also decreased nationally dramatically. Ohio tracks a little ahead of the national average now at 7.2% due to little cigar use. Then we see smokeless tobacco has decreased nationally, but Ohio has a problem with smokeless tobacco, and at about 10%. So if this is a problem mostly in boys, it could be nearly 1 in 5 are using some form of smokeless tobacco. But girls are using it now more too, as they've come out with nicotine pouches and things like that that don't produce the salivation and the things that go along with traditional using dip, as they say. And so this is being used now in schools. Teachers are finding kids are using this covertly in school to use nicotine while they're in school. So the tobacco industry keeps coming up with more ways to deliver tobacco, deliver nicotine, and sell products. Bottom line. We look at vaping products, and this is an unfortunate trend. So just in 2 years, this has gone up by 7 or 8 points nationally. And in Ohio, we're tracking similarly at about 30%. So whereas cigarettes have decreased significantly among high school students, vaping products have increased quite dramatically. And just looking at high schoolers using any form of tobacco, 35.6% are using some form of tobacco, and that is up over 50% since 2016. So we really have a situation on our hands, I think, with youth with tobacco, and the health department is prioritizing this right now. So we have many reasons for optimism, of course, with cigarette use. Since 2002, well, we crossed the line in that year, and there have been more former smokers than current smokers in the US since that year. About 62% of adult smokers who have ever smoked have quit. So it certainly is very possible and attainable for most people to quit. About 70% of adult smokers say they want to quit, and more than half have made a quit attempt in the past year. So what works? Well, what works, we know, is counseling plus medication is really the most effective way to help people quit smoking. but less than 1/3 of those trying to quit use either counseling or a medication. And we see that in that combination, which works so well, less than 5% use both counseling and medication when trying to quit. So I think this is probably maybe a lack of knowledge and people trying to go it alone sometimes, quit cold turkey. And we know people do make many cold turkey attempts that don't last very long. Talk about e-cigarettes for cessation. This is kind of a hot topic. And there has been high-level evidence from RCTs that e-cigarettes that contain nicotine are effective for helping people stop smoking. Now, that is in controlled trials, very carefully controlled trials. But there's a longitudinal cohort study that's been going on for some years that just published a paper a few months ago and found that those who use e-cigarettes were less likely to have successfully quit compared to those who used a pharmaceutical smoking aid or no product at all. So in the long term, it isn't easy for people to get off of cigarettes. They often are using cigarettes in e-cigarettes in combination with cigarettes. And 60% relapse to using cigarettes, again, often in combination within 2 years of going entirely to e-cigarettes. These products produce a lot of toxic byproducts, as you're probably aware, and they can harm the developing brain in teens. So right now, these are not recommended by the FDA as smoking cessation aids. Next slide. So as far as behavioral methods, non-pharmacological methods, we know what works best is the advice that you can give to patients, physicians, nurse practitioners, physician assistants, and nurses. It's very powerful. You're in a very high leverage position to help people quit smoking. The quit line works. Tailored self-help materials also work. Cochrane review showed that printed materials make a big difference after a discussion with their primary care clinician. And even really minimal interventions of 3 minutes or so can make a big difference. So you're probably familiar with the 5A's model. Ask the patient about their smoking status, advise them to quit with personalized messages, assess their willingness to quit, and then help them quit and arrange referrals if necessary. So let's talk about how we can use this. So we've got these diverse populations at risk. How can we relate to people across these populations, and oftentimes people in multiple different populations? So let's go to the next slide and look at that. So there's an approach called cultural humility that was developed in the 90s, and it really meshes with cultural competence, which is more knowledge-based health-related beliefs and practices and knowledge about cultural values. But this is simply genuinely attempting to understand the patient's behavior with respect to tobacco as it relates to their identity, to race and ethnicity and gender, sexual orientation, etc., as they share that information with you and being genuinely curious about it. It's probably something that most of you do quite naturally, but it meshes very well with motivational interviewing, which really is about what's important to the individual, what they value, whatever that may be for them. As the developers of motivational interviewing have written, good listening crosses cultures well, and within MI, people are recognized on the experts on themselves. And so this is really what cultural humility is about. And MI has been shown to be very effective in minority populations with an effect size in one meta-analysis twice as large as that for the majority white population. So we know that motivational interviewing is effective across diverse populations. So I want to just impart to you one quick approach that you could use in having discussions with patients about smoking or tobacco use. That is to use the ask and advise steps, advising them by talking with them about their particular health risks and how tobacco use relates to that. And then you can assess their readiness. And this can just be termed in this very straightforward question in this hypothetical scenario. On a scale of 0 to 10, where 0 means not at all important, 10 means the most important thing for me right now, how important would you say it is for you to stop smoking? And of course, we're just trying to elicit their level of motivation and their readiness to change. And this patient says, and knowing that the risks of smoking are higher than I thought, because of the advised step that you probably went through here with the patient, I would probably put myself at a 7. And then we always want to reflect change talk, and won't do that here in the interest of time. Next slide. So then the next question could be, I'm curious, why are you at 7 rather than a lower number? Because we want to understand more about their motivation and elicit more motivation from them. In this case, I don't want to have a heart attack like my buddy Dave. He's disabled now. It's really sad. I need to be there for my kids as they grow up. We reflect that then to elicit more change talk. And then the final question could be, what would it take to make quitting a little bit more of a higher priority, say to go from 7 to 8 on that 1 to 10 scale? So what we want to do is elicit what could be a small next step that you might take to move even closer to changing, closer to taking a step towards quitting smoking. And this patient says, I tried quitting with the gum a few years ago, but didn't like it. Maybe I could try different medications. Then I could put my best effort into it because I believe it's really possible for me to quit. And we see that unless patients have a level of self-efficacy and confidence that it's possible, they are reluctant to put much effort into it. So in this case, this patient is ready, it appears, perhaps to try different medications, and that discussion could then ensue after this. Next slide. So if they're not ready to consider quitting or making a quit attempt, again, you can provide printed information, and you can keep the door open by asking permission to resume the discussion at a future visit. Next slide. So we have some terrific options for referrals here in the state. So the Ohio Tobacco Quit Line is really a really good option. They offer both phone and online coaching, plus email, text, chat, and web-based materials, English, Spanish, and they have a translation service. They offer 2 weeks of free NRT pharmacotherapy, and of course, more can be prescribed after that. And they report a 37% quit rate who use both coaching and NRT, which is a remarkable rate and a very high level of patient satisfaction. We know that patients who are referred by their primary care doctor are much more likely to follow through with coaching and NRT than if they're just handed a phone number. For those who prefer, say, texting, smartphone, social media, rather than talking with someone on the phone, there's smokefree.gov. They have texting and different apps for women and teens and veterans. They also have a smokeless tobacco texting program, which has been shown to be effective. Finally, for those who want in-person smoking cessation help, there are group clinics by the American Lung Association through their Freedom from Smoking program. These are often offered by hospital systems. I know University Hospitals has one going on right now. So referrals to these resources can be facilitated, can be done through the electronic health record. And the Quit Line actually has technical guidance and assistance for IT staff to be able to do that. So you can do that very quickly, and members of your team can do it for you if you prefer to have them do that too. So there are many additional resources for quitting for special populations. This will be on the Cardio website with the presentation. And just to recap, we've got one of the highest smoking rates in the country. Medicaid patients in Ohio are smoking at a much higher rate than the general public. So there's significant work to do, but progress can certainly be made. Cultural humility and MI facilitate these discussions well across diverse populations. And we've got great resources to be able to refer people to. Thank you. Back to you, Gautam.
Thank you, Jim. Any questions for Dr. Werner about this presentation? Terrific stuff. Thank you.
Dr. Werner, this is Paul. Thank you. I really appreciate the presentation. I'm kind of curious. The one slide showed the smoke, focusing on cigarettes. The one slide showed high school students in Ohio lower than the national average, and adults in Ohio smoking cigarettes much higher than the national average. Do we have evidence, or what's your hunch? What triggers the change when you're high school age and an adult? Why do we see that increase as they become older?
That's a good question. I think that probably what's going on with high school students is that they're adopting vaping rather than adopting cigarettes initially. So they're going, since they're young, they don't have experience smoking cigarettes, but vaping is all around them. And most students say that they started vaping by getting vaping products from other people, from friends. They use them at parties. It's very common just for kids to use them, even if they don't use them often. Whereas I think adults, since vaping hasn't been around that long, many smokers have been started with cigarettes and are still using cigarettes. Even if they transition over to vaping, they're often, as we see, using them in combination with vaping and really having a hard time getting away from cigarettes.
Understood. Thank you.
Thank you, Paul. Thank you, Jim. Any additional questions before we move to our cases? All right, let's turn it back to Andy for a moment and we'll wrap up.
Thank you, guys.
Just as a reminder, in a couple of weeks is our cardio fall webinar. So you can either use the QR code here or go to the cardio website to register. Next slide. Also, all past and present Echo Clinic recordings are online. So feel free to go back through this session or past sessions. Next slide. A post-clinic survey has been sent to you. It is sent from a different email this time. We've been having issues with my UC email. But if you do have questions or concerns, I put my UC email in the chat. Please email that one. Just so everyone knows, Claire delivered a healthy baby boy this morning, and both she and the baby are doing well. And then otherwise, if you have case studies you haven't sent already, go ahead and send them to me. I should have a finalized presentation schedule next week. And that's all from me.
Okay. Thank you, Andy. Thank you, everyone. Have a wonderful rest of the week, and we'll see you next week. Bye-bye.